Luke, another question to Margie while we're just, Robert, setting up. Margie, we see the nervousness about introducing the pregnancy vaccine. We've talked women into believing they should have the flu vaccine. We've got the whooping cough one, we've got the COVID, so there's a lot of acceptance. But now we're going to introduce a story to say, oh, we're really nervous about this, but hey, it's a good vaccine. You're the expert on introducing and the language we need to use. So how do you think this sales pitch is going to go when we eventually get safety data, or hopefully get safety data to introduce the RSV vaccine for pregnancy?
Yeah, I think that's a great question. And, you know, we do have we would have 3 maternal vaccines plus COVID, so 4 for women to potentially consider. So the timing of when they would have those vaccines, I think when it comes to the RSV vaccine, my personal view is we should be really cautious and not open it up to be exposed to, because there will be, you know, premature deliveries in women who have this vaccine. So I think by personally restricting that window to 28 to 36 weeks, for example, I think would be really important. There's going to have to be really important, you know, clear post-marketing surveillance. But the message around prematurity, I mean, we don't want to be scaring women. There wasn't a signal in the Pfizer trial. It wasn't significant, but I think we are all apprehensive and cautious about this question around prematurity, especially given the previous trial. So I think the messaging needs to be really positive around the benefit of the vaccine, what it will do for infants, but that we need to be cautious around safety. I don't know if Jim wants to add anything to this. We've talked a lot about this, Jim and I.
Messaging is not my forte. The safety data is really complex. The GSK data, which is clear, showed the effect on prematurity to be greater in low and middle income countries than it was in high income countries, and there was no temporal relationship between the vaccine and the onset of premature delivery, and there appeared to be in the GSK data a 5-month window where most of that effect occurred, with the question, was there some circulating strain or something that precipitated that change that we may not see elsewhere? It's a really complex data set, and I think starting cautiously makes sense.
Jim, is there any idea of the mechanism and risk groups at all?
I'm not aware that those discussions have been shared. I think there are multiple hypotheses. I'm not aware there's supporting evidence for any of them as yet. Yeah. Or I think the company's looking very carefully. But
off target.
The only thing, Tony, is I think most of the premature deliveries occurred more than 4 weeks after receipt of the vaccine, which was interesting. And yeah, look, I mean, it's very hard to get these data from the publications. So I think I probably shouldn't say anything else, but really in terms of how premature the infants were, there was sort of that was 50-50 between very premature and only sort of slightly premature over 30 weeks. So I think, yeah, the surveillance around it is going to be really important.
Keep going, then I don't have to do anything. We've had 3 more just superb talks, and I've prepared a couple of questions while you're thinking of more for the panel. Jim, fascinating stuff, and I've been interested in febrile convulsion and viruses for a long time, so your data is very interesting. Could you comment on what might be the implications for the clinician or the public health person or for health policy more generally of the work you're doing?
I think in terms of clinicians, we can certainly, in terms of discussing with families as to why we might immunise, we can introduce a range of other conditions that the vaccine may help protect from. In some ways, the germ of this idea occurred while I was sitting on PBAC, and what we were confronted with in terms of the impact of viral conditions was often very limited data, limited to very small data sets and not terribly convincing, knowing that much better clinical data was sitting in a whole variety of data sets elsewhere. And the question was, how could we develop a methodology that gave us access to that data without compromising privacy? And then could we develop a methodology estimate. So in other words, if we can attribute a percentage of burden for these conditions to individual viruses, that aids health technology assessments and therefore policymakers in whether or not they recommend the vaccine, because hopefully we can capture the full or much closer to the full impact of a virus so that committees like ATARI can make fully informed decisions.
I'm just amazed by what Betty does in terms of analysing data sets and whether changing by time and by quality and quantity. And so I've given you a question that's come from one of the online people. I don't know if you can make sense.
Yeah,
if you could repeat it.
I think the question is looking whether vaccine effectiveness studies can help us understand the effective number of doses in vulnerable people, and also, different vaccine different vaccine types. I think they certainly can, particularly these very large data collections, because you obviously, when we talk about vulnerable people, whether it's, people in aged care or people with other sort of predisposing conditions, you need to start to have sort of significant numbers of events in order to have statistically reliable information. And you layer on top of that, someone's had 3 doses, 4 doses, bivalent, monovalent, XBB, whatever. So it does mean you're sort of cutting the data into quite small bits. It's one of the reasons why we've really pushed for certainly the linked data in Australia to include outcomes such as hospitalisations, where we do have more serious events, and we can try and look at some of those questions, particularly around some of the vulnerable populations, where I think better evidence is needed to sort of inform vaccine recommendations in those groups.
I know there's questions, but I've got another one. You can wait. Not long. Controversial question to you, Margie. Given the importance of maintaining confidence in our public health approaches and vaccination, I seem to read between the lines that you're suggesting maybe we should start with a monoclonal antibody for RSV and then introduce vaccine for pregnant women, or were you not going quite that far?
No, I wouldn't be going that far. I think it's very exciting to think about a maternal RSV vaccine, and I think, as I said, introduced cautiously, potentially like the US, and going with a narrower gestational window, whether it's, I'm not sure what that will be, 28, 30, 32 weeks, I think makes sense. I think the vaccine's effective, and I think being able to capture women in pregnancy is great. But I think that the monoclonal antibody offers a huge advantage as well. And how these programs will work together really does remain to be seen. There will be some high-risk infants that may have both, and there'll be obviously women who don't receive the vaccine in pregnancy who then can get the monoclonal antibody at delivery. So I think it's incredibly exciting to think that we do have both of these options, but how it works together, I actually think is going to be quite complicated. And we've got about 12 months to figure it out, I think.
Rod.
Yeah, thank you. A question to all the panel that we were challenged to say that we need to be able to produce new vaccines within 100 days. So my question is, which one would you back if you were saying which technology, which future technology would you want? And do you reckon we're going to have safe vaccines for anything, any syndrome, any disease X that Cantor throws at us in the next 10 years? Which vaccine would you go for, and which one do you think is going to be the safest and easiest to introduce, just having had a COVID experience?
I think regionally, I think dengue is such an attractive candidate. But asking someone who spends most of their time in vaccine safety to make confident predictions around dengue vaccine is bloody hard. I think the Dengvaxia experience made us realise that we can evaluate safety properly after several years, noting that the Takeda study does have 5 years of data, which so far is reassuring. I think the complexity around serotypes for dengue makes it really difficult, and whenever a decision is made for global implementation, it will be with some girding of the loins, no matter which platform they use. But that's the most attractive to me in the short term. The malaria vaccine implementation is incredibly welcome. The new data from the RIT program is really exciting. Locally, I think RSV is very exciting. There are other candidates coming down the line, and Shingrix, which is being introduced, offers immense disutility reduction. In other words, the pain of herpes zoster and neuralgia is immense, and that's what got the original Zostavax funded. And if we can impact and reduce the amount of post-herpetic neuralgia, that's a major plus.
The only thing I was just going to add, Robert, was that we're actually doing a discrete choice experiment through Gen V here in Victoria and beyond, using an online panel to actually ask pregnant women and women who have a child under the age of 2, what are the attributes that would inform their decision-making around a maternal vaccine versus the long-acting monoclonal antibody. So I actually think asking women is really important as well.
I agree. Ian Barr.
Margie, I wonder if you'd like to comment on the unpublished, unreviewed data coming out of Spain on nirsevimab. And secondly, what's your feeling about the best use of nirsevimab or other monoclonal antibodies for that matter? Should they be given all year round, or should they be given just before the season or during the season?
Well, I mean, personally, I think it should be given all year round. I think it's very hard to pinpoint the RSV season, especially looking at the data, over the last few years. So I think having an all-round program makes sense. I think it should be offered to all infants. I think equity is going to be really challenging, and how this is going to be funded and available to all infants. But of course, the greatest benefit is going to be to the higher risk infants. Yeah, I don't know. That's probably all I would say. Don't want to comment. Sorry. I don't know if you want to comment, Jim.
It looks great. It's really going to come down to what's the most, 1, cost effective, and 2, practical way we can implement it. And at the moment, all we know is the private price in the US, which is $500 a dose, which, oh, sorry, I take it back, okay, because I like you, $4.95. So first of all, compared to the palivizumab, that's a bargain. And so at least for the very high risk babies, we can make a much better case for it. And it almost certainly will be cost effective for a proportion of babies. And that's great news, because they have the highest impact. In terms of general population, it'll be a question around 1, cost of use, but 2, how can you practically implement a program with, and I don't have the right answers for that yet.
And the other thing I think, we really need to be aware of is, it's just gone out of my head. It's not only around price and acceptability, but the Indigenous infants in Australia as well. I think, in the Northern Territory, the program, I think, is a priority. And that's what I was going to say, vaccine supply shortage. We need to be really aware of the demand for this product. And we've seen the supply issues in the US, and that could happen again tomorrow. So I think both programs are really important.
Just my last question for Betty. What would be your take-home messages for most of the relatively healthy, relatively middle-aged people in this audience? And what about for their high-risk patients?
Look, I think for the relatively healthy, and I'll make the assumption that most people are sort of under 65, 70 look, I think, if people are sort of up to date with their current COVID vaccines, I think that, that's, providing people with good protection, and certainly your risk, your baseline risk of having serious disease is, relatively low now compared with earlier periods in the pandemic. For the older population, vulnerable groups, you know, obviously risk is much higher, and it's particularly in that aged care population where I think we need to be focusing a lot of our efforts and making sure that people are getting regular boosters. And that's what, you know, looking at the evidence, I still think that we will need to be boosting those vulnerable populations, you know, regularly, whether it's 6 months or whether it's a little bit longer. I think that's up to the target.
And I'd agree with your earlier comment. There's been a real failure to vaccinate, and John Litt mentioned that as well in aged care. That really one thing that we could really get out of this conference is do better for our elderly population. I'm going to wrap it up unless there's any. Did Tony, you have the last question there?
No, I think the only really interesting question for Betty in the future will be when we get vaccines that are aimed at infections, such as the influenza vaccines that have just been deployed in China from Hong Kong. There'll be a list of those and how we actually match those with the RNA vaccines in the future. Just a thought.